sonography. Being able to perform abdominal sonography will make all the difference. So, our next patient is scanned in the echo lab, as I heard from you. I'm very curious.
This was a male patient, 72 years old, with hypertension and a systolic murmur, and he came for planned echocardiography. He had no symptoms, no clinical symptoms, and felt quite well. So what do you think, Christian?
I think the left ventricular function is quite okay.
Yes, he had...
Isn't it?
Yes, it's okay. And he had a mild aortic stenosis, which explained his systolic murmur, and he had left ventricular hypertrophy.
But there was something special about
So that's not very exciting. But now, when I performed a subcostal view, I found something strange. So what do you see?
Okay.
The left liver lobe at the top of our picture, and there's something in that should not be there.
Yes, you're right. I think it's a bad surprise.
Yes.
It looks like there are hypoechoic lesions in the liver.
Yes.
One is greater than the other over here. And when we find hypoechoic lesions in the liver, this could mean malignancy. There are some few cases when the lesion is benignant, but most likely this will be a malignant tumor, maybe primary or secondary.
That is what we thought too. And so we scanned the rest of the liver, and sadly we found other lesions, like we see here.
Okay. Now, you used an abdominal scan?
Yes, and use an abdominal probe then.
Okay.
It's not so easy to detect, but we can see some hypoechoic lesions again. Maybe you can stop the picture. And here, also at this picture, so highly suspicious for malignancy. And of course, we thought, where would a primary tumor be if this would be metastasis?
So you went on performing
an
ultrasound scan of the whole abdomen.
So what do you think of this picture, Christian?
So what we see here is the pancreas, this hyperechoic organ over here. And at the end, in the tail of the pancreas, we see a hypoechoic lesion, which is quite great.
Yes, it was a big one, easily seen.
And every hypoechoic lesion in the pancreas is suspicious for a malignancy. So further diagnostics has to be done.
Yes, we did a CT, and our diagnosis was confirmed. The patient had a carcinoma of the pancreas and multiple liver metastases and intrapulmonary round lesions, and also suspected osseous metastasis. So the patient was treated at the oncologic department. And this is a quite sad case because this patient came without any clinical symptom, just for a routine echocardiography, and went out of our ward with a diagnosis of advanced cancer.
So the key point is the ultrasound beam does not stop at the diaphragm. When you see something in the neighborhood, go on with scanning, continue to make an ultrasound, in this case abdominal ultrasound. It wasn't so easy to see, but when you are going for our course and you learn how the liver would look like, you will see that this was not a normal liver.
The next case is one of a pregnant woman who came to our ward in a life-threatening condition.
It was early in the morning when I get a call from the obstetrics department that abdominal sound is needed because the pregnant woman has intensive pain. So from my clinical routine, I expected a gallstone or a stone in the kidney. So I started with the scan of the right upper quadrant.
The gallbladder seems normal to me.
No gallstones?
No gallstones, exactly. But there is something nearby in the vicinity of the gallbladder, which disturbs me.
There was this glance of free fluid over here, only some drops maybe of free fluid. So I continued the scan and scanned the lower abdomen.
Oh, and there seems to be a lot of free fluid in here. We can see the intestine, that are these hyperechoic structures over here, and in between we can see the black fluid, which means there's free fluid in the abdomen, and this shouldn't be there.
I stop the image and will show you these dark areas show no echo, so there is free fluid, and free fluid in the abdomen can be ascites or, in this case, blood. So it was a really life-threatening situation. So I went on, and in the case of bleeding in a pregnant woman, we have to think of
the baby,
extrauterine gravity. So I was looking for the uterus, and there was a normal pregnancy in the normal uterus, and so I was very confused about it.
If you look closely, we can also see the little heart beating over here.
The blood
Luckily,
tests,
yes.
the blood tests were normal. There was no decrease in hematocrit.
But anyway, she had a lot of abdominal pain, with a quite sudden onset, and free fluid in her abdomen. So, what did you do then?
There was a strict indication for operation, so the patient went to the operation room, and what was found was a twin pregnancy, one baby in the uterus and another pregnancy in the fallopian tube, which ruptured and caused a severe bleeding which would harm mother and babies. So the fallopian tube had to be resected. And the interesting is that all lab tests did not show the severe hemorrhage at this time.
And what happened to the baby after the operation?
Luckily, the baby survived, and mother gave birth 28 weeks later to a healthy baby. So the baby and the mother could be saved.
That's a nice case.
By ultrasound. In our next case, we are concerned with a female patient, a teacher who had undergone hysterectomy the day before, and there were no complications during the operation. But in the following time,
I was on call the next night, and the patient was in increasing abdominal pain since about an hour, and my colleague from the obstetric ward called me to help her. She had already performed an ultrasound scan of the lower abdomen because the patient localized most of the pain over here. And she thought maybe there would be blood in the bladder and asked me for a second look.
So that's the first scan you made from the lower abdomen.
Yes.
And I think over here we can see
the bladder.
The bladder?
Yes, you're right. It's empty, so it's not so easy to detect. Why is it empty? Because post-operative, the patient has got a urinary catheter.
But the structure we are concerned is this over here. Hypoechoic and hyperechoic, and
quite big.
Quite big. Maybe that's an hematoma, correct. But not in the bladder. It's near the bladder, I think.
Right. I thought so too. I could not detect blood in the bladder, but this hematoma over here. So I was a little bit concerned that maybe the bladder had a leak because there was a little bit of blood in the urine. And so we filled the bladder retrograde through the catheter with saline solution. Okay, and luckily,
I can see it here.
We detected no leak.
Mm-hmm. The bladder was filled. And just seen over here. Okay, no leak. So only one hematoma?
Yes, but of course, I did a complete scan of the abdomen and I saw something else.
Ooh, over there. We can see the liver here and the kidney over here. And now when we take a close look, in between these organs we see these areas without echo, echo-free areas, which means free fluid in the abdomen. So a patient after operation with free fluid in the abdomen.
What could it be?
Blood. I think
Of
that's
course.
blood.
So we took blood sample 2 of the patient, and she already had dropped with her hematocrit. So this was an acute indication for an operation. The patient went to surgery, and some major bleeding of some vessels was found and could be solved.
Do you have any pictures of this?
Yes. Luckily, my colleague took some pictures of the surgery site, and here we can clearly see that there's a lot of blood around the liver over here. It was really life-threatening, and was a good case for me because we could solve this problem immediately. And for us, the key message is,
if you see free fluid after an operation, this is likely blood. And so surgery has to be done.
Our next case has got a different teaching point and a little surprise.
There was a female patient, 30 years old. She came to our hospital and complained about pain in the back, in both flanks, and in the right upper quadrant. She already had a stone in the urinary tract years before, and she was sure that there's a problem with the kidney. So a younger colleague of mine did the scan of the right kidney in transversal and in longitudinal scan. Do you see anything? Over here we see the green margin shows where the liver is, and the purple one the kidney, and in the inner area of the kidney there is the renal pelvis, and there is no dilatation, there are no stones, no liquid found. So I think there's no problem with the right kidney. But we went on scanning the patient, and another organ get into the view over here.
I think the gallbladder is quite full, and I can see an object over here which is white, hyperechogenic, and could be gallstone.
Maybe, so go on. And here we see the gallbladder filled with bile, it's anechoic, and over here we have this bright area, this bright reflex is the gallstone, and behind the gallstone there we see acoustic shadowing, which means there are no signals from ultrasound from behind the gallstone because they are blocked at the surface of the gallstone. So behind the very dense structure, like a gallstone or ribs or bone, we have no signals, which means acoustic shadowing. So I told the patient, we have got the problem, a gallstone, and you have to be operated.
And did that explain her pain?
To me, yes, but the patient told me, don't mention the gallstone. I have got this gallstone since years and there's no problem with this. And other doctors also told me this gallstone will never make any problem.
So what did you do next?
The thing was, when I touched the gallbladder with the transducer, the patient told me about pain. So I knew the problem is the gallbladder and not the kidney.
So it's a positive so-called Murphy sign, isn't it?
Correct. I went on scanning. And do you think anything is wrong in this picture? Or is there anything
Yes, I see another
additional?
object over here with acoustic shadowing. So maybe there's another gallstone.
Correct.
And this one at this place could cause a lot of pain, I think.
I displayed already the answer. There are two gallstones, two shadows, two gallstones. One of the gallstone is located over here and blocks the flow of bile, so the patient has got pain and the colic caused by gallstone.
So what about an operation now? Did the patient agree?
Yes, finally the patient agreed because we showed her both gallstones, and when we performed the scan and she felt the pain while I'm scanning the gallbladder, she was
Convinced.
That's the problem. And we told her 2 gallstones are the same price in operation than 1 gallstone.
So she was convinced then?
She was convinced the operation was done and the problem was solved. So key point number 1 is, when I touch the organ and the pain occurs, I've got the problem found with sonography.
And the second point is that it's not so difficult as you might think to scan the gallbladder with ultrasound. And it's also not so difficult to detect this stone. Maybe it needs some more expertise to detect the second stone, but we will teach you all of this in our course of basic abdominal sonography.
So let's get this expertise and try to find the gallbladder. We go on with scanning. Where do we expect the gallbladder? The gallbladder is inferior to the costal margin in the middle of the right upper quadrant. When we perform the physical examination, we put our hand here, put pressure on the patient's abdomen and ask the patient to take a deep breath. Please press in. We try to feel the gallbladder and test if there is any pain the patient reports. The same procedure is made by the transducer. We put the transducer over here, put gel on it, and find the gallbladder, ask the patient to take in a deep breath, and when the patient reports about pain, we know there's an inflammation and a positive Murphy sign, the positive sonographic Murphy sign. Diseases of the gallbladder are the most common indications for abdominal sonography. Sonography can answer the question whether there are gallstones with or without inflammation, if there are biliary obstruction, or whether there is a tumor or something like this in the gallbladder. In order to achieve the best examination conditions for sonography, it is important that the patient does not eat anything 6 hours before the scan. So no oil intake will improve meteorism and will enlarge the gallbladder. So also chewing gum, coffee and smoking are forbidden. We have to keep 3 things in mind. First, ask the patient to lie onto his left side and raise the arm above the head. Second, take plenty of gel. The more gel you use, the better the view. And third, give the command, please breathe in and hold your breath as long as you can, and afterwards go on breathing normally. Place the transducer at the midline of the patient's abdomen and make sure to keep in contact with the costal margin. Now, transfer the transducer along the costal margin to the right side of the patient and follow the picture on the screen. When we will do so, we can see the inferior border of the liver. And when we follow the costal margin, we can see the gallbladder over here in a quite longitudinal scan. In order to achieve the best picture, we have to rotate the probe clockwise or anti-clockwise to get the gallbladder as large as it could be on our ultrasound machine screen. So this is a perfect image of the gallbladder. Now we can do our measurements. The diameter in the longitudinal scan of the gallbladder is up to 8-10 centimeters. In the cross scan, the diameter is about 4 to 5 centimeters. We can also see the bile, which does not contain any echoes, so it's a black echo-free area inside the gallbladder, and the wall of the gallbladder is quite bright, hyperechoic, and we can measure the thickness of the wall. We have to make a sweep through the whole organ, and we are looking for stones, wall thickening, sludge, or even tumor. Nothing of these findings can be seen here. It's a normal, healthy gallbladder. So, when we found the gallbladder in the longitudinal scan, we have to perform a transversal scan. So, we rotate the plane 90 degrees counterclockwise and keep the gallbladder in the middle of our screen. And the same procedure is done by tilting the probe upwards and downwards, so we can be sure that there are no stones, inflammation, or something else. So we scan the gallbladder in two planes. In the longitudinal plane, with a sweep to the patient's left side, and the other way around to the patient's right side. And in the transversal plane, in the cross scan, when we rotate the plane 90 degrees counterclockwise, we perform a scan tilting the probe downwards, which means the cable came upwards, and the other way around, tilting the beam upwards, so we can see the entire gallbladder in 2 dimensions. That's very important, and we perform this kind of scan on every organ in the abdomen. Gallstones, liver metastases, and problems with the bladder. That's what we have seen so far. But there's much, much more in our course of abdominal sonography.
And it's not so difficult. You can learn it too. We are there for you. And we will teach you everything you need to know to help your patients.